Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Matthew Haddon, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Hi, I'm Matt, and I am so glad to be on the show. It's been great listening to previous episodes, and I'm particularly interested in this area of participation. Today, we're so happy to have the one and only Dr. Sarah Reedman joining us on the podcast. Hello, Sarah, and welcome.
Hello, Sarah.
Hi, Matt and Dana. I'm so excited. I'm so grateful to be here today, and I can't wait to hear what you are going to grill me on.
Oh, if you could see the smiles on our faces, we're actually really excited about this. We've talked about this sort of work for a long time, and to have you on the show is great. And to have Matt join us is even better, because I know he's been really interested in this area as well, as a new graduate physiotherapist, looking at how we can implement research into practice. This is a really great opportunity.
Super excited to have a chat, Sarah.
All right. So as per usual, I know Ash is usually the one that brings up the icebreakers. So it's my turn today. We know that a great way of getting to know who we are is through our coffee order. Now, coffee orders are complex. If you're the person that's been allocated to go down the road to pick up the coffees, you usually have to kind of have a whole list of it. There's all different kinds. There's different kinds of milk. There's different kind of foams. There's flavors. There's so much to go for. So I think you can tell a lot by a person by their coffee order. So Sarah, I'm going to start with you. What is your favorite coffee order?
I have to go for a one-shot almond latte. That's my standard. I don't really deviate from that. Maybe that tells you something about me as well.
I like it a lot. Almond lattes are quite popular around here as well. So that's a really good one to note. Matt, what is your favourite coffee order?
Well, for me, I've recently changed from a cappuccino to a flat white, and I can sort of see myself going down that path of heading towards long blacks and espresso shots. But currently at a flat white level. So gradually, moving up in those ranks. And how about you, Dana? What are you? I know you're a coffee lover.
I'm way down that track. I remember my progression of cappuccino to flat white. I am now just black coffee all the way. In fact, yesterday I think I had about 6 shots. Ooh. It was a big day, and I just love my black coffees. I think one of my friends actually said to me, really successful people have a black coffee. And I'm like, well, that's it then. I'm just going to stick with my long black coffee order. It's a good one. It gets me through the day.
Lovely. Awesome.
Well, now we know a little bit about each other. It's a really important area. We're really excited, as we say, we've got Dr. Sarah Reedman here. We'll be reviewing the article published in 2021, very recently, in Developmental Medicine and Child Neurology. Her paper is titled Participation Predictors for Leisure Time Physical Activity Intervention in Children with Cerebral Palsy.
And the lead author of this paper is Dr. Sarah Reedman, who is a postdoctorate research fellow at the Queensland Cerebral Palsy and Rehabilitation Research Centre Group within the University of Queensland Child Health Research Centre. When it comes to participation of young people with disabilities in sport and active recreation, Sarah's work is at the forefront of the area. She has actively contributed to this body of knowledge and has presented this work across the globe. As well as this, she's also involved in large multi-centred trials across Australia.
Yeah, it's quite an amazing CV, and I have to admit, I have heard Sarah speak before. One really notable one was the European Academy of Childhood Disability in Poland, where all of us Australians were up in the middle of the night trying to make sure we didn't have croaky voices as we were presenting, and that was an amazing presentation. So it's no surprise, if you know anything about me already, that this paper really resonates with me. And I think there's some really practical things here that we can take away from this paper, and the things that we can really look at in terms of the outcomes and different kinds of predictors as well. So I can't wait to get into it.
Yeah, for me, this paper is just such an exciting step towards filling such an important gap in evidence-based interventions that improve participation for children with cerebral palsy. So really excited to get into this. Over to you, Dana, to talk about the features of the article.
Fabulous. We'll go through our usual pick-off format. So there were 33 children with cerebral palsy who participated in this waitlist randomized controlled trial. The children were aged between 8 and 12 years and were classified within GMFCS levels 1 through to 3. So with regards to the intervention and the comparator, well, in this waitlist randomized controlled trial, participants were randomly allocated to commence the participate intervention immediately or to enter the waitlist where they were to receive the intervention 16 weeks later. So the intervention was a leisure time physical activity intervention, which consisted of 8 60-minute face-to-face individual and tailored physiotherapy sessions over a period of 8 weeks. The between-group differences were evaluated after the intervention and at follow-up. Now, in addition to this, a range of questionnaires were used to understand the predictors of change. The aim here was to determine the predictors of magnitude of change in response to the intervention. Now, for the really exciting outcomes. Now, within the randomized controlled trial itself, the primary outcomes was the Canadian Occupational Performance Measure, or the COPM, and they found significant improvements in goal performance and satisfaction following the intervention compared to control. Now, there was also no between-group differences in minutes per day for moderate to vigorous physical activity after the intervention when measured using actigraphy. Now, when it comes to determining the predictors of magnitude of change in response to the intervention, they found that motivational and behavioural determinants in health behaviour predict change to the intervention in terms of the perceived activity levels after the participation-focused intervention. They found that age and comorbid ASD diagnosis explained 49% of the variance of change in the COPM performance. And importantly, they found that being motivated by interest or enjoyment, physical activity competence or appearance, parental autonomy, supportiveness, and overcoming barriers were elements that predicted participation.
Well, what an incredible body of work, isn't it, Dana? And
it is.
Before we go through the results, Sarah, it would be great to talk about the intervention itself in a little bit more detail. The intervention was really underpinned by the self-determination theory, not something that's known to all clinicians and researchers. So would you be able to explain a little bit why this theory was so relevant in this context?
Yeah, great question, Matt. Self-determination theory is a kind of macro theory of human motivation and behaviour, courtesy of Richard Ryan and Edward L. Deci. Basically, it's got kind of two major elements. The first being what's called basically basic psychological needs theory.
Yep.
That's to say that humans have these 3 basic psychological needs, being autonomy, so kind of finding our own way,
yep.
Competence, which means needing to do something and then whatever the outcome is, that's what we want it to happen, and relatedness. So just connecting with other people and feeling like you're a part of something bigger. And that when those basic psychological needs are fulfilled, we're able to have self-directed or self-determined motivation to achieve the goals that we want to achieve in life. And Edward L. Deci and Richard Ryan have tested this across almost every population that you can think of, including children, and found that really it holds true, and that if those needs are fulfilled, then we can achieve the goals that we would like to achieve, and particularly in physical activity. So when people have these needs fulfilled, that they really engage in physical activities and they keep doing it and keep persisting in those activities, which is so important for our health and well-being. And the reason that I chose self-determination theory as something that I thought was really important for this population was that, people with disability, including children with CP, are just people, and we all have these basic psychological needs. We all have these motivations, and it was just something that I thought we really need to explore this further in this population, because it's something that really no one had looked at before.
For sure. Absolutely. And so it is really just about what makes people want to do the things that they do. And it's definitely, as you say, an area that really hasn't been explored a lot, particularly in this population. So super, super interesting.
Yeah. And I think it makes sense. The minute you describe it in that kind of way, you go, well, that's such a missing link, isn't it? It's understanding the why component of it. Would you say this is one of the first papers that's looked at this in our population of children with cerebral palsy?
Yeah, absolutely. To my knowledge, it's the first paper of this kind to explore kind of behavioural and motivational determinants of health behaviours, and one of those being physical activity behaviour, not only in children with CP, but also in other populations or clinical populations, so people with health conditions and people with disability. There's a lot of literature about this in typically developing children and typically developing adults. But I think that misses the mark a little bit because, as we know, it's people with clinical health conditions and disability that are actually most at risk of having low levels of physical activity and having participation restrictions and not participating in physical activities and sports.
Yeah, that's such a great one to talk about. So, I mean, in the last few podcasts, we've talked about this with several people now in terms of physical activity and the importance of that. And I love this angle now. You call it this health behavior paradigm adoption. It's a beautiful way to describe it. So can you talk a little bit about how you use this self-determination theory within the actual intervention itself? What does that actually look like?
Yeah, great question, Dana. So looking at physical activity as a health behavior really changes the way that you think about it as a clinician and think about how you clinically reason to address that. If you think about health, sort of the traditional way of looking at physical activity is seeing it really like as a product of people's physical competence.
Yep.
That if you get better at like running and walking and stuff, that you will automatically do more physical activity in your daily life. And while that's true to a certain extent, of course, physical capacity does predict physical activity. It's not a secret. If you then realize, though, that even typically developing people without health conditions can have low levels of physical activity, you realize there's obviously something else more at play here.
Yeah.
What other barriers could there be to people's physical activity participation and their physical activity level, if not for their physical competence? And so thinking about it as a clinician and then what that involves would be exploring some of those barriers so that you can actually target those in your intervention. And so in Participate CP, that involved really having a holistic approach, trying to gather all of that information. So I used a technique called motivational interviewing, which is a kind of a specialized technique of it's actually directed towards health behaviors, but really any type of empathetic listening works. Actually connecting with people, finding out what's going on in their life, and using your clinical skills to think about, okay, what are the environmental factors? What are the contextual factors? What are the child-related factors that could be barriers to this child's participation?
Absolutely. So you can see how that is relevant. I mean, here we're talking about physical activity and we're talking about that in terms of participation, but you consider what our role as clinicians is really to have the opportunity to listen. We talk about family-centered practice. There's a lot of paradigms we're talking about, but to bring it into this context and sort of saying, actually, let's look at this from your perspective. What is it that you want to achieve out of it, and identifying the barriers applies to everyone who's working into this field. So I think that is really unique in itself, the actual intervention, the theory. The other thing that's really unique about what you've done is you've employed a waitlist randomized controlled trial. We know that randomized controlled trials are a high level of evidence. Can you explain to all of our listeners what a waitlist randomized trial actually means?
Yeah, so a waitlist randomized control trial basically means that it's built on a standard RCT. So you've got your two-group comparison. You've got one that gets the intervention usually right away and one that acts as a control group. And now in a waitlist RCT, the intervention that gets assigned to the control group does actually still get the intervention, but just after that RCT period has completed. So in the case of Participate CP, you had one group gets the intervention immediately for 8 weeks. Then both groups actually have an 8-week period where they have usual care. And then at that 16-week mark, the intervention group are finished and they're gone. They've done their bit in the trial, and the waitlist group can then actually receive the intervention. What that allows us to do is two things. One, it allows a little bit more fairness because it means that the children who get allocated to the control group still can receive the intervention. So there's that equity issue is dealt with. And the other thing is that it actually allows us to pool the data. So what happens is when you have a standard RCT is that if you want to look at, for example, what might predict change in the intervention, you've only got half the sample. If you can have both groups receive the intervention, it means that you can pull that together and you have greater power to look at potential predictors of change, which allows you to look at the mechanisms of action, which is so crucial for us to understand why something works.
Yeah, definitely. And I think those 2 points that you mentioned in terms of the fairness, but also from a data pooling point of view is really, really useful. And I suppose now to go a little bit into the results, Sarah, you did note that from some amazing results that you found in your paper that there was also a sort of reduced performance and satisfaction scores in the COPM for older children. And that, you talked in the paper a little bit about why that may be the case. But would you be able to explain to the listeners why you think that is?
Yeah, that's a really interesting point. So we found that children who were older had a slightly attenuated response to the intervention. So what that means is even though their participation, performance and satisfaction still improved, it improved less than if they were younger. And so the reasons for that, of course, we can only really speculate because we don't have the evidence to back that up necessarily. But what we think is that basically there are a lot more barriers that come into play as you get older, and especially as you're aging with a health condition and disability. So in typically developing young people and adolescents, we see a quite marked decline in their participation in physical activities. And there's been some work to understand why this might be. A lot of people say that it's because of things like self-esteem and changes in self-efficacy, peer group relations, children finding different activity preferences. So they just start to enjoy different activities more that aren't physical activities. The schoolwork coming into play, having less time to be physically active. And so just so many different things. And it's a fallacy to believe that those things don't also affect adolescents with health conditions. They do. So we really need to just think about what are actually the realistic reasons why this could be happening. And perhaps from a clinical perspective, what that means is that we need to pay special attention to this group of older children and adolescents and find out what other things are going on in their life and understand that perhaps we actually might need to provide more therapy, so like additional therapy to help resolve some of those extra barriers, or that we might need to take a different approach. And of course, you can't always do that in an RCT. The idea is, this intervention was individualized, but you can't change everything. It's, you've got to keep it somewhat standardized, if that makes sense.
Absolutely. And that's the challenge of this area, isn't it? It's such a broad heterogeneity. We keep talking about that. That word comes up constantly because it's just so true. And, that's why it's such an amazing achievement having done this kind of study. I know how much work goes into it, and to be able to standardize an intervention is fantastic, but it gives such a great platform to talk about these other things that we want to find out about, this individualization. So now talking about these older kids, because, I think now we're sort of going, okay, well, what do we do? What are some of the things that we can really think about? And I'm going to go back to this whole motivational orientation that you bring up in your paper. Essentially, you're looking at the motivational determinants of physical activity behavior. And you sort of talk about, what are they motivated to exercise for fun, for capacity, for participation, or extrinsic reasons. And then you had these questionnaires that you use to help to determine that. Can we talk about that and sort of the kind of questionnaires that you used and maybe how we could possibly use that for helping us to decide what we can do for older children perhaps?
Yeah, great point. So the questionnaires that we employed, one of those was called the Motivation for Physical Activities Measure Revised, or MPAMR.
What a great acronym. I love that.
Very well done.
That's right. Love an acronym. It's a self-determination-based theory questionnaire. And basically what it's trying to do is elicit how a person is motivated to engage in physical activity. So, and as you mentioned, Dana, it's are they motivated for more intrinsic reasons, being like kind of just for the fun of it, doing things because of interest and enjoyment, and I guess that's the holy grail of self-determination theory. You want to move people towards intrinsic motivation for physical activities by fulfilling their basic needs. Or are they motivated for physical activity for extrinsic reasons? So that's reasons that are traditionally thought of or as a whole as being rewards and punishments.
Sure.
So if I exercise, my mum will give me a chocolate bar, or I only exercise because if I don't, I'll get in trouble. But then there's also sort of a spectrum in between, right? So there's other things that are in that middle ground, which would be perhaps I exercise because I know it's important, which is not really an intrinsic way of thinking, intrinsic motivation, but it's not extrinsic either. It's about kind of aligning physical activity with your goals and values. So the idea behind using this was actually to find out what each individual child's motivational orientation or motivational profile is. What kind of makes them want to do physical activity? It's not wrong to be extrinsically motivated for physical activity. That's probably like a big misconception that like everybody has to be intrinsically motivated for physical activity. It's just not true.
Such a good point.
I know a lot of adults that are extrinsically motivated for physical activity. And understanding that is actually a great way to make your intervention more effective, because you can target it better and you can use effective behaviour change strategies depending on how a person is motivated.
Yeah, and when you say that, again, I love the practicality of how you talk about that, because I'm just, as you're talking about that, I think about myself and what motivates me, and I probably swing between the two depending on where I'm at. You know, sometimes you just know you have to do it because that's what you just have to do because you've got no other time. So it's nice just to say you can't put our kids into these boxes and say you're intrinsically motivated and you are extrinsically motivated, so this is where you're going to stay. I love the practical nature of it. And so with this questionnaires, how easy are they to be used in community clinical practice? Like, what does it involve?
I think they are pretty easy to use. So there's a couple of different ones. Of course, I used only a few, and there were 3 questionnaires. One was that MPA-MR. One was called the Problems in Schools Questionnaire, which is actually a parent-directed questionnaire. And that's probably more of a research-oriented one that may not necessarily apply in clinical practice, because you're trying to find out information about how autonomy supportive a parent is. And that's not always kind of clinically useful information. The other one was the Physical Activity Climate Questionnaire. And then that's actually quite an interesting one, because it tells you information about how the child perceives their parents, caregivers, and other people in their life, like perhaps a PE teacher or coach, how autonomy supportive they are with regards to exercise and physical activity.
Yeah.
If you think as a clinician that you need to know this information, and so that would be because, for example, you think, gosh, this child is not participating well in their PE classes at school, and I'm a little bit curious about why that is. That could be a measure that you decide to employ. They are freely available and they're easy to score.
Yep.
Similarly, for the the motives and physical activities measure, it's short and it really gives you insight into where the child or young person is at now. And can actually help open up a dialogue. I think it's something that we don't often talk to kids about.
So true.
We don't talk to them. What motivates you?
Yeah.
And kids, I don't know why that is, because kids are so capable of talking about that. Yeah. They're so capable of actually having insight into their own motivations. And it can just open up a beautiful field of questioning and practice that even I, as a clinician, hadn't explored prior to doing this.
It's really interesting, really unique to explore what those children have to say as well, and how that can shape your intervention. Another thing that you used was the GAS, the Goal Attainment Scaling. It's so individualized, so objective, but you do also note that the GAS has some limitations, particularly when dealing with participation-based goals, which all of the goals were for your project. Would you be able to talk us through a little bit the way that you use the GAS and the COPM together to help sort of tackle and unpack these goals?
Great question, Matt. The COPM was the kind of overarching goal-based measure that we use. So all participants in the intervention had to use the COPM to set participation goals. And all of those goals had to align with the family of participation-related constructs.
Sure.
So for those who aren't familiar, that means that they had to be an attendance goal, so being there, or an involvement goal. And then the GAS kind of sat underneath that. So all of the GAS goals that we set had to reflect barriers to those participation goals.
Yep.
So, for example, while the COPM goals were all in the domain of participation, and they had to be, the GAS goals could actually take on any domain, but usually not participation, because it's really hard to say that participation is a barrier to participation, if you know what I mean. So that's why, that's why there were no participation GAS goals, because it was kind of self-evident. If you're not participating, you're not participating. We didn't feel like that was going to be very easy to interpret. So that's kind of like, to give you an example of what a GAS goal might be. So if the overarching participation goal was, I would like to ride my bike with my friends in the neighbourhood twice a week, then one of or a couple of the GAS goals that might be related to that could be in the activity domain, perhaps about bike riding competence. So being able to ride a bike in a straight line without training wheels for 100 meters, and then, the increments related to that. Or it could be more like an environmental factor. So actually scheduling the time to make that happen. And that could even be at a parent level. It wouldn't have to be necessarily related to the child, because the barrier is more the parent actually making the time, supervising the activity. So that's an example of an environment level GAS goal.
Yeah, it's really interesting. And I love how you did use the GAS to address those barriers. And what that also showed was that addressing the barriers among different levels of the ICF also help demonstrate that improved participation in the COPM, and a really sort of interesting sort of stat on the side as well, which relates to the COPM and changes in the scores that you saw. We talked a little bit about age before, was that the prevalence of ASD, autism spectrum disorder, which is sort of really in line with the work that's been done in the area. Well, I guess a few weeks ago, Magnus Parliament has done some substantial work in this area, and we see that with the decreased change in COPM performance, you talk about the need of extrinsic motivation. What do you sort of see when running the intervention practically for this?
Yeah, so this was, I guess, a finding that came out of my own clinical observations. It wasn't a hypothesis that we had in the beginning when we set the study up. It was actually like a post hoc kind of decision after we did the study, and we realised that probably there are quite a lot of additional challenges that children with a comorbid diagnosis of ASD or autistic children faced. And so we found then that actually having an additional diagnosis of ASD, which is about a third of our sample, had that effect of also having a slightly attenuated effect. So they still improved, but it was less than children who didn't have this diagnosis. And I guess there are a couple of different reasons for that. You mentioned the potential need for more extrinsic motivation for physical activity, which I think is something I discussed in the paper. So when I had a look at the literature to try to unpack why this could be, that's something that I found. So there are a couple of studies that talk about how the motivational profile of autistic young people, and that they actually might be more extrinsically motivated for physical activity and exercise, that they need structure, they need routine, they need the people just to set up the opportunities for them to be able to participate in an accessible and inclusive way. And that makes sense to me. I think it makes sense. And it's like intrinsic motivation is actually a little bit nebulous and it's not very logical. So we found that a lot of the young people, autistic young people in our study, just said, it doesn't make sense for me to do physical activity just for fun. I really need a reason for it, and I need to be accountable for it, and I need to have opportunities that meet my needs. And at a base level, I think that makes sense to everybody. And I think it also tells us that tailoring is just so important. And we, as I said earlier, there was a certain level of tailoring that we were able to do. In fact, quite a lot. But still, it was limited to what we were able to do within the confines of the standardized RCT. So just listening to what people want, what they need, and how they would like things to go is something that we should all strive to do as health practitioners, because it's going to allow us to be more effective.
Yeah. And, again, you've described this. It's so in line with the literature where things are at the moment. We mentioned Dr. Magnus Pullman, who was on our show a few weeks ago, and he talks about the prevalence of ASD, and it's higher than you'd expect. But when you look at your practice, you go, actually, it does make sense. We as clinicians need to have a wide variety of skills to be able to consider this. And that might seem overwhelming. But then if you take a step back, you go, okay, well, if I actually just ask, and get more dialogue and information, it's less overwhelming because then you're understanding the reasons. And the last thing I sort of really want to talk about is you talk about the just right challenge mantra. Like, I love a good mantra, and I love the just right challenge. And it's in line with what we know about motor learning and learning new skills. It's very consistent. And you talk a little bit about, children might have had some previously negative experiences. Can you talk us through that a little bit? Because I think we've all encountered those cases before, and what your thinking was and how you went around that to support these children.
That is such a fantastic question. I'm so glad that you brought that up, because one of the reasons that we decided to use self-determination theory in the beginning was because we know that negative physical activity experiences are so prevalent in this population. Yeah. And what a negative physical activity experience does is undermine those basic psychological needs.
Wow.
So it undermines a person's relatedness because they might be made fun of, or they feel like they're different to others. It undermines their need for competence because they have an experience and they feel like they've done a really bad job, and so they have low self-efficacy. And it undermines their autonomy as well because they feel like they have restricted choices and that are not, or perhaps choices that are not available to them. So really, it's those negative physical activity experiences work in this repeating negative cycle. The more that a person's psychological needs are undermined, and the less willing they are to try, and the less intrinsically motivated for physical activity they are. And so being able to almost apply a Band-Aid to that and try to turn that around was something that really, really motivated me.
Yeah.
So what we found was that those children who actually had the lowest confidence to achieve their physical activity goals were the ones that improved the most and the ones that showed the greatest changes in their. So they had low self-efficacy for physical activity, and they improved their confidence to achieve their goals the most, which means that when we apply an intervention that is at that just right challenge, and what I mean by that is it's just right physically, so that's, the motor learning aspect, right?
Yep.
But it's also just right for self-efficacy.
Yep.
So it's just challenging enough that it makes a child realize that yes, I can do it. It promotes that feeling of competence.
Yep.
And it's also just right in a social sense, so that they feel like, I'm physically active with others, I'm relating to them. Sure. And it's also just right from an autonomy perspective. They feel like they've got just enough control over the things that they're doing, that we're able to meet those needs and provide that really positively reinforcing experience that makes them more intrinsically motivated to be physically active. So, just right everything.
Yeah, just right.
That's my
One message, just right, exactly. Oh, it's just fascinating. And you've talked so much about how the self-determination theory can, be incorporated into so much of this and underpin so much of this program. And we have mentioned a little bit about, where to from here and what the future holds. But yeah, I suppose, would you be able to summarize a bit of where you're hoping that this future research is going to take us and what you'd recommend future clinicians and researchers to be looking into?
Absolutely. So we're already looking at this in a broader population of Australian children. So we've got a large multi-site, again, waitlist randomized control trial. And this incorporates slightly older children. So we're looking up to the age of 14. And we're also including children classified in GMFCS level 4 as well. So I'm really, really excited to see the results of that trial, which should be available more towards the end of next year. And I've just started a pilot intervention, or about halfway through, in a younger group of children, so between the ages of 4 to 7 and GMFCS 1 to 5. And importantly, I think, and most crucially important to me, is that we're including children that have severe intellectual disability and other health conditions, because I think it's those children that face the greatest participation restrictions and are most at risk of negative health consequences of physical activity. And I know that you're really passionate about this too, Dana.
Yes,
so
absolutely.
It's really great.
I know, gets me excited hearing you say this.
Yes, it's so exciting. And we've just seen some great anecdotal results already, which I'm just so happy about. So this is where the future is. I think it's around. Also, if I have some research heroes in this area, it would be people like Olaf Fischer and the 24-hour cycle, and also the integration of sleep and nutrition. And, those kind of things just light a research fire in me. That's where I think our future direction goes. The other thing that I would say is that if you are a clinician who mostly works with young people with complex disability or physical health conditions, is that we can learn so much from all of the public health research that's being done in just typical or general populations.
Absolutely.
I think sometimes we just try to stay in our lane, and that's not always the best thing. It's sometimes good to broaden your perspective. If you're talking about physical activity, well, you should be learning about physical activity, what's the big stuff happening in the general population, because all of that stuff applies to all of the young people that we're working with. And certainly that's where I drew my research from, and I think why things have been such a great success.
Oh, that is exciting. Oh, Sarah, that's definitely lit a fire in us as well. Well, that leads us into our next segment, which is called Tell It to Ed. So as we know, Tell It to Ed is a 60-second pitch to the common man Ed. Ed is our producer, not a background in child health, but he is coming a long way. I'm very, very impressed. So this is a great opportunity, Sarah, for you just to, in about 60 seconds or so, explain your research to someone who might not have a background in child health. Take it away.
Oh, great. Okay, Ed, hopefully I get this right. So what we did was we conducted a intervention trial, which means we provided some physiotherapy to young people with cerebral palsy who can walk or use a walking aid. And the aim of that was to really see if we could improve their participation in physical activities and sports in the community, and also their level of physical activity. One of the things that this particular paper looked at was when we applied that intervention and gave that therapy, what things predicted a better response. So if what factors actually said, this child's going to have do really, really well with this therapy, and what factors say maybe this intervention needs to be changed a little bit. And those factors were really interesting. So we saw that children who were older didn't do as well. Children who had an additional diagnosis of ASD also didn't do as well. But the other factors that we saw a really good or increased outcome were things like achieving lots of incremented goals. So if they achieved a goal related to those barriers to participation, that they did really well. Also, if children had low confidence in their ability to participate in physical activity at the beginning, they were the ones that improved the most, because we were able to apply an intervention that really spoke to the needs of those particular children. So I guess, in a sense, what we were trying to do was just prove that when we're working with young people with CP and young people with physical disabilities, that all of these motivational factors and the things that influence people's physical activity hold true, and that this is something that we really need to focus on in this population.
That is a wonderful summary, Sarah. I think you did a great job.
Yeah.
Thank you. All right, to Ed, over to you. Do you have any questions?
As usual, I have lots and lots of questions, but only time for one. I guess I really love the whole motivation aspect, and that's quite intriguing. I guess I use the word intriguing almost every episode, but all the topics are great. But obviously from a motivation perspective, you mentioned right at the very start, empathetic listening. And I love that, because obviously having come from, I've gone through a few medical procedures. So I've come across like great doctors and not so great doctors. And I guess people who kind of relate really well and people who don't. And I'm intrigued as to like the whole motivation aspect and the empathetic listening skills of a clinician. How important are they? Like I feel that from my own perspective and experience, like I would think that that's really important for doctors. How is that when you're dealing with children who obviously have conditions that need to be managed? And is that like the starting point for a clinician?
Great question. This is something that I feel really passionate about. I absolutely believe that having empathetic listening skills and being able to apply that in a clinical scenario builds the foundation for a great therapeutic relationship with your patients, because it shows that you understand where they are at this moment in time, that you have an empathy and an understanding of where they've come from and what factors influence all the decisions that they make in their lives. And that taps into, again, I'm the self-determination theory queen, people's experiences of their relatedness. It helps to build that connection with the person that's supposed to be helping you out. And it can help build a person's autonomy if you can show that you really understand their situation. And by doing that, it kind of, allows you to build that therapeutic alliance with someone. So if you as a patient believe that your health practitioner understands where you're at, and kind of like, say if you're a parent of a child with a disability, gosh, you've got so many demands on your time. You've got so many demands on your finances. You've got so many demands on everything. And it's actually really hard to make changes in your life and your routines. Like, parents control what kids do, right? So like a parent has to be the one to drive their kid to the football game. Like they, they've got to do those things. And so it's actually just really hard. And one thing that can make it easier for that person to overcome what we call ambivalence to making those changes is feeling like the health professional is listening to them and understands them. So that's why I think it's just the bare minimum foundation for us to succeed in this area.
That was a great question, Eddie. Well done. Yeah, it's a call to action, and you can see the fire that is ignited in Sarah there. So I absolutely love that.
All right. Well, that wraps us up for the episode. Sarah, it has been so great chatting to you, and we've just loved how much you've explained this intervention and what we can do as clinicians and researchers in this field, and really exciting to see where you're taking research to from here, looking at children, older children, younger children, and across all GMFCS levels. That's so important, and so excited to see what you continue to do in this area, doing incredible work.
Thank you so much, Sarah, for being on the show. And we can't wait to have all the people listen to this because we're excited even hearing it. And, to all of the listeners out there, of course, the run sheet notes are available on our website, researchworks.net. If you want to know more information or know the links to the actual article itself. And of course, if you want this recorded as part of your CPD requirements, there's a form you can fill out on our website so you can keep that as a record of your actual PD itself. But for now, thank you very much. We can't wait to have you guys join us again next time. And thank you, Sarah, for being on the show. Thanks, guys. Bye.
Thank you. See ya.
Thanks. Thank you so much.